We may now begin with the next session, Plenary Session 1, Re-engineering the Consumer Experience. May I invite all the panelists, session convener and moderator on the dais. The convener for the session, Mr. Alam Singh, Advisor LexisNexis. Moderator of the session, Mr. Pranjal Sharma, Consulting Editor, Business World Magazine. The panelists for the session, Mr. Avinash Saurabh, CEO and co-founder, Zuju.be, Mr. Saurabh Arora, CEO and co-founder, Liberate.com, Mr. Prashad Tandon, founder, 1MG, Mr. Vivek Srivastav, CEO, Healthcare at Home. May I request Mr. Alam Singh to kindly begin the session? Sure.
Charles Darwin famously said, "It's not the strongest of the species that survive, nor the most intelligent. It's the ones who are best able to adapt and respond to change." So this session is going to talk a little bit about adapting and the kind of opportunities that the digital ecosystem brings forth for health insurers to look at. The digital health space has had many innovations in the last few years in India. Globally, there's been a lot of different experiments. Many things have evolved. We have to recognize that internet and the business models that it's incubating are transforming entire industries. Many of the millennials, the term we use to describe people born after mid-80s, they never visited a music shop or a travel agency. They buy their music, consume their music online. All travel products are bought online. They never stood in a queue at a railway booking ticket counter because they buy the railway tickets online, right? They don't skip work to watch cricket because they're streaming it on the phone while at work. And their favorite channels aren't on TV, they're on YouTube, So they may not buy everything online, but a lot of their product and service research is online, and we have to appreciate that fact. In the US, a BCG study indicated that 75% of motor insurance purchase decisions were based on online research, but only 25% of the purchase was actually done online. So we have to differentiate between the transactional facilities and convenience of the internet and also understand its larger ability to influence decisions beyond the transactions. So just as a little bit of background figures, we all know that, there's about 6.7 billion mobile phones in the world, almost as many as humans. There's 2.7 billion internet users. There's 1.7 billion social media users. And in India, we now have about 900 million phones. Globally, we're the second largest phone market after China. We have 250, almost 300 million internet users, and more than 100 million plus Facebook users. So the whole digital ecosystem, it offers vast opportunities. By 2020, 1 out of 2 humans will be online. The smartphone penetration is exploding. In 2013, more smartphones than regular phones were sold. That was the first year when that changed. And just to give you a little bit of context, it took 110 years for there to be 1 billion landline phones. It took 49 years for there to be 1 billion TVs. It took 22 years for there to be 1 billion mobile phones. It took 14 years for internet to hit 1 billion users. But it took Facebook only 8 years to get to 1 billion. So the change and the opportunities it's bringing in are rapid. This session is going to focus on some of the opportunities that the digital health ecosystem offers. Insurance, like all other industries, is not immune. We have very interesting examples. Oscar is the first health insurer to have an investment by Google. Within less than 2.5 years of their existence, they're valued at $1.5 billion. That's about 9,000 crore, exceeding many established Indian players who've been around for more than 10 years. That's just the beginning of, how technology and insurance are going to converge more and more in the future. So I turn this session over to Pranjal to take it forward. Thank you.
Thanks very much, Alam. You've set the stage in a very interesting way, and I'm really here as a consumer. So I'm not a practitioner, I'm not a technology person, but I'm very keen to learn about how a consumer experience, and I think all of you would see yourself in the shoes as a consumer at some point or the other. I would like to just right off the bat begin by inviting all our panelists, because they are doing some really exciting and innovative work using digital technologies, and what Alam laid out in terms of how digital technologies are giving access to 500. So among the figures that he said, I think what is also important is to know that 590 million people are unique mobile phone users. So the figure is 900 officially, but unique users are 590 million, and it's growing as we speak. The thing is that can that be used as a fantastic vehicle and a network to reach out to people who are outside the mainstream? So while a lot of work is happening on financial inclusion, what about health inclusion? How do we use that not just for the people in the cities, but also for a market which works at different price points, which is evolving faster than we realize, but it's there for everybody in the ecosystem to tap, if we can find the right models and the solutions. So maybe I'll begin from my left and request Prashant to begin. So all four of them are innovators, as I said, and what I'm requesting them to do is give a quick introduction of what they do and their perspective on how they are contributing to improving the consumer experience. Thank you. Prashant.
Thank you. Pleasure to be here. I'm the founder of 1MG, which is a digital health app. So it's basically focused on medicines and everything around medicines. As an application, we have around 4.5 million downloads, around 5 million visits monthly, coming from roughly 1.5 million unique people who visit or use our application to access information around medicines. Also, we run an e-pharmacy marketplace through this network, and an e-diagnostics marketplace where people can buy the medicines and the diagnostic tests that they need through the platform. So we are in the business of basically providing more information and more access to consumers through the digital platform. So the order comes to us from a consumer. We understand their health profile, we get their prescription, and then have them fulfilled. So it's a pretty simple, straightforward model, but everything is digitized, all the data is available, and a lot of data we get thanks to the 5 million monthly visits that we get. I'm happy to answer any specific questions as we go along.
Prashant, if I can stay with you for a second. How do you let people know about that you exist? How do people get to know about you?
Yeah, so that's a good question. In our case, people let people know that we exist. So most of the growth or marketing actually happened on social media and virally. People shared WhatsApp messages with each other that this is an interesting app. It was why did that actually fundamentally happen? Because consumers are hungry for information right now. And we were fortunate to be the first ones to provide it in a format that the consumers felt comfortable with. Information on medicines, information on healthcare, people are looking for that. What was the gap in the market was one credible platform that could actually give it to them in a manner that a mobile consumer wants to consume. That's where we come in. So most of our growth has been without any specific marketing. It's been largely organic and social media driven. And so the fact is that people are looking for information now. If as enterprises we are not able to cater to that demand, it's a problem. If we are able to cater to that demand, it's a huge opportunity.
Hi. So I am co-founder and CEO of a company called Zuzubi. To start with a fun fact, Zuzubi is a name that is inspired by Rajnikant's dialogue. So Rajnikant has this very famous dialogue called Yenna Raskala Zuzubi. So every time he defeats the bad guy, he'll say that. Zuzubi colloquially means easy, and that's exactly what we are trying to do. We are a behavior change platform. We help people form great habits, like running, jogging, doing yoga, taking stairs at work, and so on. uh, Habit formation traditionally, people mostly rely on motivation or guilt. If you're very motivated to go to gym every day, probably you will do that. Or if you have a sense of guilt because you smoke, you would want to quit. What we are trying to do as a company is understand how do I give you more reliable and scientific ways to change your behavior. With that said, we are positioned as a workplace wellness platform as of now. We are helping companies drive positive behavior change within organizations. We have around 70,000 employees spread across 5 countries using our platform. Clients like Mindtree, Unisys, GE, Aditya Birla Group, and so on. But I think most important of all, what we are trying to achieve here is a fundamental shift in the way in which we look at the data that we are collecting from an insurance perspective. Traditionally, all the data that was being collected was an episodic data. When you start an insurance policy, you get a health checkup done. Or even within companies, you do a health checkup once a year. What we are doing, because people take these challenges on our platform, track those activities and behaviors, we know so as to what is happening between these 2 episodes. And we are bringing that fundamental shift where we are moving from an episodic data collection to a continuous data collection, which has huge impacts on the way in which your insurance premiums are decided, for example. So in short, that's what we do.
My question is for a consumer, what do you offer me as a consumer or as an employee, individual employee? How can she or he leverage the information that you're gathering? Is it accessible to the person? If so, how?
Right. So let me put it in perspective. So I'll give you an example. Let's say Pranjal wants to run 10 kilometers every day, and that's the habit which he wants to form. He can come to our platform and say that, hey, this is my goal. We take in basic set of information like, have you done this before? Do you work out and things like that? And based on that information, we can actually tell him that, Pranjal, forget about running 10 kilometers. You cannot do this on day 1. Why don't you just simply run 1 kilometer for next 3 days? And you can link it to your Fitbit, to your activity trackers, Apple Watch. And every time you do that, we know that you have done it. And when you achieve that goal, we tell you, okay, great job done. Here's some points, virtual points, share the achievement with everyone. But here's your next goal. Now run 2 kilometers for next 6 days. And so we gradually build you up to the habit that you want to form. There are 3 core principles. If you look at the science behind habit formation, there are 3 core principles.
Yeah, so sorry to interrupt you, because I just want to if you're making the elevator pitch, then I want to ask you the quick question again, that how does that tie into my health insurance?
Right. So I'll give you an example. At Mindtree, the data is public. That's why I'm mentioning the name. We have driven around 10% of the organization at Mindtree when we started were not involved in any physical activities. Over a period of 6 months, we were able to show data, behavior change data within the organization. 10% of the organization is a huge number. We were able to show that 10% of people who were not doing any physical activity before logged onto the platform, took these kind of challenges like running, going to gym, doing yoga, and continuously tracked that behavior over a period of 5 months. Good enough to form a habit, good enough to drive a behavior change. We are still far away from linking it to your insurance premiums. The data needs to be slightly more mature to do that. But I think we are on a way to do that.
So basically, you will create a health profile which I can possibly use for this in future, right?
Yeah, correct.
Okay, thanks very much.
Sure.
Saurabh, may I come to you and ask you to introduce what you do?
Yeah, hi. So I'm from Library, which is a healthcare community. Okay, sorry. So Library is a healthcare communication platform that connects users with doctors. So in a country as big and diverse as ours, there are only about 1 doctor for every 1,700 patients, and the ratio is quite skewed if we go outside metros. So we are currently in Delhi, fortunate to have a greater penetration of doctors. But if you go to tier 2, tier 3 towns and cities, accessibility is a huge problem. Second problem that currently exists is convenience. In order for us to take care of our health, if you're facing some minor issues, or there's a feeling of breathlessness, or for example, having a backache, for the past week, we find it hard to get ourselves to go and meet a doctor. A 10-minute doctor visit can result in a 3-hour affair, from being stuck at traffic jams to waiting at doctor's clinic and coming back. So essentially what we do is we make it super easy. We make it seamless. We make it super easy for users to talk to doctors. And that's the platform that we have, wherein anybody here would be able to, within 5 minutes or less, would be able to talk to a doctor either through a text chat, or you could find yourself talking to a doctor or a voice call or even a video call.
So in some ways you're an aggregator of all the doctors who are in the market, and you allow access through your platform. Is that right?
So we don't call ourselves an aggregator. So what happens is we are in the business of democratizing healthcare, if you were to use that word, right? Democracy is supposed to bring in access, equal opportunities for everyone.
So my question again as a consumer is that sort of, if I come to Librate, how do I know about the credibility of the 80,000 doctors who are on your system?
Yeah.
How do I choose them? How do I charge? How do I get paid? How do I pay them? And what kind of redressal is there if I am misdiagnosed or if there's an error?
So couple of there are like 5-6 questions clubbed in that small statement. So one is how the doctors are sort of selected and how the doctors are. So we have a in-depth verification process. So any doctor that comes on Library, it goes through a series of verification process, and once we are sure that he is a real doctor, then only he comes on the platform. As far as the payment is concerned, doctors are free to choose their own fee, set their own fee. So we are not in a business of dictating that a doctor consultation is X rupees, right? So all doctors, they are free to choose their own fee. Similarly, what this means is, as a user, I can go to a doctor which has a 50 rupees consultation fee versus a 5,000 rupees a consultation fee as well. That's the range that we are operating.
So is that transparently visible or
Yes.
available?
It's transparently visible, available next to the doctor's name, at multiple places, and users can make a payment using their credit card, debit card, net banking, and they're free to sort of see the doctor's credentials, his degrees, his education details, and sort of
All this is visible on your
Yes.
platform,
All
right?
this is visible on the platform, and users are free to choose their own doctor.
I'm sure many people are already visiting his site and say, like, can we just call a doctor just after the session is over? But that sounds very exciting, and I'll come back to you a bit more about how that is. And I think you made a very good point. We were talking earlier as well, and we had a chat before this on how the whole health insurance sector globally is supposed to keep people away from the hospital, but in India the health insurance business seems to be looking to push people into hospitals. So that's a fundamental that we need to address in a little while. But Vivek, may I come to you and talk about your efforts?
Yeah, so I am the co-founder and the CEO of Healthcare at Home. I founded this company for the Burman family. It's a joint venture between the Burman family and founders of Healthcare at Home UK, which is a $2 billion company having presence in UK, Australia, and mainland Europe. So what do? We provide high-end home healthcare services. So we've done hundreds of oncology procedures, including 10-hour chemotherapies, blood transfusions. We've set up critical care setup at home. You can think of us as a distributed hospital. So 70% of what all can be done in a hospital, we have done that at home in India. And there are some other businesses which we are also, delving into. One is in pharmacy distribution. So we are doing high-end specialized medicine distribution. We also have a company which works with pharma companies to do patient support and patient access programs, so that more and more people get under treatment. So those are the large three things which we do.
How do you reach out? How does that work?
Multiple ways. So one is like all the other people reach out, Facebook, Google, and RWA camps, and so on and so forth. Then we also work with doctors and hospitals. We also work with the pharma companies, And actually, we have started working with some insurance companies as well to reach out.
Okay, so I'm going to stay with you, and then the question I'm going to ask you, I want the other panelists to answer. What are the gaps in the linkages you see, or what are the opportunities and linkages with the health insurance sector that can benefit both? So would you like to begin, and then maybe I'd like all of you to just jump in as you like.
Sure. I think you mentioned that the health insurers should actually globally try and push people out of the hospitals. Here it's the other way around. I think what we are trying to do is enable them to push, or enable them to push people out of the hospitals, primarily because it's not that it's only about cost savings, but it's about patient convenience, like you mentioned. It's safer, it's convenient, it's more effective in terms of clinical outcomes to be there, treated at your home, and we are enabling that to happen. And in the process, obviously, it saves about 15 to 20% costs. Globally, the health insurers are covering this. So whether it's UK, Healthcare at Home UK's first customer came from an insurance company. Whether it's US, there again, Medicare and private insurance covers home care. In mainland Europe as well, Germany, Switzerland, places people have covered, through insurance, in Australia as well. So globally, it's there. It's just that the Indian insurance industry has started seeing it, but it's a long way to go.
So do you, Vivek and Saurabh, do you compete with each other? Do your companies compete with each other?
No.
It's okay to compete. There's nothing wrong with that.
We are in completely different segments.
So anybody else wants to jump in, please feel free.
Would pitch in. I would come to Archana's point, which she was mentioning in terms of insurance, that it should move from sickness and should also start promoting health. And so the question is, how actually do you do something like that, right? We can keep on optimizing the processes that exist. We can keep on strengthening or cutting the losses at all the places, but it is only going to reach to a local maximum. How do you actually create a global maximum for the processes that you have? And for that, you need to fundamentally rethink the way in which we are looking at the entire ecosystem. It's the consumers who have to drive those change, and the focus has to shift to consumer experience. Giving users platforms to take care of their health, be it by connecting to doctors, or be it, even before that, forming habits and taking care of yourself. That's the place from where you actually start generating data that could give you valuable insights into the premiums, for example. I am a firm believer of the fact that if me and Pranjal buy the same insurance and he runs every day, he should be paying less premium. But how do you actually achieve something like that? So giving people such behavior change platforms, or giving them tools that can help them stay true to their health goals, could be one of the ways to achieve it.
Made a very great point that there should be a difference in premium with regards to how I take care of my health. In fact, in US, your car insurance is tied to the number of sort of challans that you get, number of tickets they call it in US. In India, we call it in car insurance something like a no claim bonus. Although it's abused in multiple ways, but that's what it is called. Right? At least it's incentivizing the driver not to. It's incentivizing driver to sort of drive safely. But in health insurance, we don't see any such thing. So I think there's high time that, insurance companies sort of, get to the point that, hey, our business is not to sort of, get users to the hospital, but how do you prevent them? And the way to incentivize is financially. If you say that, hey, if I and Saurabh, I'm like, working from 9 a.m. in the morning till 10 o'clock, sitting at desk, all day, I'm at, I should be paying a higher premium compared to the other person who is sort of taking care of his health. So I think that's one way to sort of, work together and change the dynamics.
Yeah, I would largely echo what has already been covered, which is health insurance fundamentally needs to think about how can we stop people from going to hospital, how do we incentivize them to a better behavior. And there are 2-3 things that can be done. One is, of course, be a partner in that journey and provide incentives. It's been well known that models like pill pack or home-based medicine access have increased adherence. When you are in touch with your consumer, adherence increases, basically the patient's health in chronic conditions is certainly seen to be better. You take care of your fitness, your wellness, always great. Small things, you get treatment at home, don't need to go to the doctor or don't need to go to the hospital. It's all these help keep the patient away from the hospital. And I think fundamentally insurance needs to start working towards those kinds of products. The other thing I think what India has been lacking is insurance just starts at the hospital. So there are hardly any OPD or pharmacy related insurance products. And I understand there are fundamental issues why that is tough to administer, tough to price. There's fraud. There are a lot of small individual bills. But what is really happening with technology coming and concepts like I would say e-pharmacy ourselves, with everything is digitized, everything is already can be presented in a format that works. So it's actually possible to create new products that cover categories where the unit processing cost otherwise was making it infeasible. Also, fraud detection. On a technology platform, so much easier to set rules and methods to detect and monitor fraud, even at scale. So I think insurance, once they start thinking of that we need to get involved earlier in the process, we need to come with incentives, and those incentives actually include new products that the consumer engages with earlier in the life cycle. I think that's what will be best for the industry. And innovation that is happening in the digital space, pretty much everyone sitting here, it's basically keeping a person away from the hospital. So I think insurance has probably the maximum incentive to actually participate in that. And so far, I think we haven't seen much, and I'm really looking forward to seeing some.
So the question, and please allow me to be provocative, question is why? Health insurance companies and other insurance companies, you have so much global presence, why aren't they engaging and using the digital formats the way that they should be? Anybody wants to answer that? Or let me put it this way, not to sound too negative, what can be done to create a more constructive approach and engagement?
So I can start just quickly.
Yeah, sure.
Just elaborating on what I was speaking. So in the outpatient setting, all transactions are on cash, on paper bills. It's a 200, 300 rupee doctor consultation and a 300 rupee pharmacy bill. I understand that just the practical cost of processing thousands of these will make premiums unfeasible. So it has to be digital. It has to come through platforms that can make at least processing of these claims, both in terms of processing means fraud management as well as just digitizing them and putting it into the system. So I think we have to make transactions costs lower for which we consumers, and the primary goal so far that I have been feeling has been to process their to basically calculate the financial risk and then process it, rather than how can that risk actually be reduced, and how can we move to a system where it is much more one, personalized based on a person's condition, and secondly starts much earlier in the cycle so that the big cost actually never comes.
Thank you. You wanted to add?
Yeah, so I agree with what Prashant said, that the costs and the fraud, etc., was one reason why they're not doing. The other piece which is very important is the clinical outcomes itself, right? So if you are outside the hospitals, the control over the clinical outcomes reduce, and that's where, credible players like us who have history, of 20 years doing this in the UK, with superior clinical outcomes comes into play. You see, the UK market was 85% captured by Healthcare at Home UK. There are examples in the US where the companies which were clinically more competent were able to, in the long run, capture the market, in a disproportionate way. So as you see these kind of credible players coming into the market, the insurance companies have started actually looking at it. So whether it's the home care companies coming in, whether it's the the doctor chains which are coming in, or whether it's people like Liberate who will come in, who will be able to give them credible information so that they prevent fraud, and then also don't compromise on the clinical outcomes.
Query and curious about that. Are the models and the way you operate in UK different from how it's going to play out in India? Or, I mean, do you see differences?
Well, there are differences. UK is a completely paid market or funded market. Whether it's insurance, whether it's NHS, they completely cover it. India is a largely out-of-pocket market. So there it was more the doctor or the hospital deciding the way of the treatment basis the customer's choice, and the money never changed hand. Here money changes hand. So that's one fundamental difference. But I think the foundation of the business remains same. If you provide superior clinical quality, if you provide superior patient satisfaction, so I think that's one of the themes of the discussion. You will be able to replicate, because Healthcare at Home UK was able to replicate this in multiple other countries. So it was UK different, Germany different, Switzerland different. I mean, everywhere it was different environment, but the fundamental principles was clinical quality, high patient satisfaction, and it will work.
So I just want to add that what it will make for insurance companies to kickstart. I think the answer is that it has to be the proof that hey, this thing works. So I can sit here today and say that we are a wonderful platform, we reduce friction, which we do. But what is important is for the other side, the other party who is the listener, to say that hey, this is actually this actually works. So I think the onus is also to some extent on us as well, sitting here, that hey, we can actually replace it, we can actually reduce the cost. So for example, if I say that today a user who comes on Liberate and he has some early symptoms, and sitting through his home, he was able to talk to a doctor which suggested lifestyle changes and also suggested some tests which were sort of successful in early detection of symptoms that could lead to severe problems later on, right? So that's a classic use case in which I can say that, hey, yes, I should support this initiative from the outset and get more and more users under my sort of scheme, under my folks, to sort of say that, hey, I'll sort of subsidize some bit of your plan towards preventive stuff, right? So that you are able to stay healthier. So I think we need to show proof. We need to build case studies to actually convince the other party that hey, this system works.
No, that's I think a very important point, and that sort of answers in some way what I was referring to earlier. Is how do you get yourself known? How do you provide the credibility that you need to be able to grow and engage with larger players and important stakeholders in the system? Because even the regulators, the policymakers need to know whether these digital solutions are working or not, or are these, to use a government phrase, a pilot project which is working well for maybe 20 people or 100 people or maybe 2,000 people. But in the Indian context, scalability is so critical. So I have one question which is which I would like all of you to address, and then maybe bring in some thoughts from the audience, which is linked. One is about scalability. And linked to that is the fact on what we discussed earlier about inclusivity. So how do you, when you scale, you don't just scale in metros, you need to scale beyond these cities, and with the ecosystem which is going to be digitally connected. What are the challenges and opportunities you see in scaling up to maybe tier 2, tier 3 towns, and I don't know what the opportunities are. So maybe I'll begin with you, Prashant, and come across if all of you can answer this and keep adding to the points which have not been made.
Sure. So in terms of scalability, I think the technology-based businesses, the backbone has to be solid technology, and that's fundamental to making any system or platform scalable. I think that's the area we actually invest quite a bit in. A lot of people, when they think of a digital business, they think it's just an app and just a website. The reality is a lot goes in the back end. We have a 60% technology team working just to make this platform work across the board. So I think the systems that are scalable are systems that have a solid backbone of technology, and then the right processes, of course, that are delivered through that technology. On the other part, on inclusiveness, these are democratic platforms, so accessible to anyone and everyone. The 1.5 million uniques that come to our platform, they come from pretty much every state, tier 2, tier 3, tier 4 of the country. And it's amazing how fast people in smaller towns and how hungry they are for any kind of information and access.
But
So,
sorry, Prashant,
yeah.
isn't language an issue here?
I am sure language is a issue which it's hard for us to tell exactly, because just with English we are seeing this kind of response. I'm sure if we increase it further, the response will only go up.
So I assume all of you are offering the services in English, right?
Just one second. I think language is an issue, but that issue is going to get solved, because we are certainly working on local languages. All of these are solvable issues. So everything won't happen today, but over the next few years, you'll see a lot more local language-based applications also come up in whichever area it is seen as relevant.
But you would say that there is a market in non-English markets, right?
Totally. I think in terms of information and product access, it's easier. I think Saurabh would know more about direct doctor consultation, how they facilitate it. But the platform is inherently scalable. It's about finding the right supply base to cater to the demand as it comes. So if it can be solved, it can be solved through a solid technology platform. That's what I feel. And then it is inherently scalable.
Thanks. And Avinash, how do you go beyond Mindtree?
Right. So I agree with what Prashant is saying, that scalability has to come through technology. But while we bring in scalability through technology, inclusiveness as a thought or as a concept needs to be rethought. Now, here's the reason why. How do we measure the effectiveness of healthcare at any country? Maybe number of doctors per 1,000 people could be one way to do that, right? But as technology improves, can we not get rid of metrics like that, right? And let me give you an example. Chronic disease management today is at a stage where chemical industry was some 30 years ago. It's a highly specialized job. There are doctors who know and understand how to recognize patterns and give people certain set of options. But at the same time, there are patterns which are emerging. Two people who are of the same health profile who are aged 30, and if they have risk of diabetes, will have most probably similar lifestyle changes to do and similar lifestyle issues to address. So there's a pattern that emerges, and all those patterns can actually be productized as technology scales. So why do you need a doctor to address a chronic disease like diabetes, which can actually be addressed or to a large extent addressed through technology like mobile apps? So the inclusiveness question needs to be rethought in terms of how do you actually define inclusiveness? Is it access to doctors for everyone, or is it because we are scaling technology, can we fundamentally rethink so as to what inclusiveness in itself means?
My question, my answer to that is very simple. 590 million people have mobile phones today. How many can you reach?
590 million. But the problem is you cannot reach everyone on day one.
No, I'm not asking you to reach everybody. I'm saying how many would you like to reach? How many can you in theory reach? I mean, if it's accessible, will it be accessible to everybody? Would you be able to have the diversity of the regions and the demands? So the question is that I know you don't have the answers now. It's going to evolve. But my question is, you have to keep these things in mind as you, and what referring to what Saurabh said, as you offer proof of concept.
Right.
You have to be able to prove that you can do it at a much larger scale. We don't want 100 people offering the same thing in a very fragmented way, because it may not be the best way to go ahead. But then maybe Saurabh, you could add to that.
Yeah, I think there are two issues to it. One you already touched upon, which is language. So we particularly see on our platform when folks come from tier 2, tier 3 towns and cities, they're not able to write in English, right? So they know the English keyboard, but they can't say I am unwell. They can say mujhe fever hai ya mujhe bukhar hai. So what they do is they improvise. That's our human tendency. So we write in English, which is essentially mujhe is M-U-J-H-E. So doctor on the other side now understands that this guy cannot understand English. I cannot reply back in English, which is he used to, right? So MBBS is taught in English. It's not taught in Tamil. right? So what he does is he replies back in English, right? So that's the sort of, the language is, I think it's a very important point, that platforms like these, I can't say today sitting here that, oh no, we cater to, a lot of users, we have X million users, without being localized. Because the fact is, when people talk to a doctor, 95% of the consults, and this is not live rates data, but this is otherwise, they are in local language. Even today, when I go and talk to a doctor, I'll talk in Hindi, even though I'm speaking in English today, right? So that's part one. The second part, I think, which is sort of a constraint when you go to tier 2, tier 3, is the payment mechanism. How would you, enable $200 or $100? The guy used to cash. He lives on maybe a 10,000 a month salary, right? He can afford a 50 rupees doctor consultation, but he doesn't have a debit card. He doesn't have a net banking account, right? He is not transacting online. So how do we, enable those transactions, the payment mechanism which he is used to? So e-commerce to a certain extent has tried to solve this problem by cash on delivery. COD is a innovation in India, not from Western counterpart. Interestingly, in all the innovation that you see in Western countries are done by companies. So I'll take an example of Airbnb.
Yeah, but I'm sure that I don't know if you've thought of it, but the business correspondent concept in financial inclusion rides on mobile technology, where a lot of payment, deposits and credits are accepted using mobile technology. So that's potentially an area to look at.
So yes, so that's one thing that we need to improve upon, as to whether a person in tier 2, tier 3, tier 4, as you go down, does he have a mobile wallet, right? So there are success examples in Africa and other countries where
No, it's happening in India. Aadhaar-based systems are now rolling out in very aggressive, because payment bank licenses have been given. They'll start rolling out in 2016.
Exactly.
So just a
that payment,
point to flag. Yeah.
Yeah. So going forward, if we can enable and ease the mode of payment through mobile phone, I think that will greatly add to the inclusivity concept, that everyone has a true access.
Great. Thank you.
So I think there have been few points which have been raised, and advantage which we have is we have a mix of technology-based models plus physical presence, right? So our technology is enabled to measure 300 different parameters. You can send out automated reports, but the advantage we have is that we are going inside people's home physically as well. So if we have to if we have to cater to a person, let's say in Sikar, which is 90 kilometers from Jaipur, and we have done those cases, we have been able to reach out to them because of our presence, which is central in Delhi NCR, Jaipur, Chandigarh, Bombay, but we can individually cater to different patients, and we have done that across wide variety of northern India now, and we'll spread ourselves across. The advantage is, the point which is not covered is, hospitals cannot go beyond a certain point because economics does not work out for them, right? So if you have to build a hospital, the capex should be able to, the capex done should be recoverable. But if you have to do only one person as an ICU in a remote village, we could do it, while a hospital will never be able to do it. If you have to cater to that person to do any kind of service, we can go and set that one patient up and then come back and be able to do that services, and we have done that services. And I think so all the challenges which we have talked of, whether it is your reach in terms of language capability, so our people speak the local language, so it's easy to understand. They can decipher what a doctor says, even if he says in English, and can cater to the local population. The collection mechanism for us has been, obviously all the technology enabled stuff is already there, whether it's credit card, whether it's payment, payment gateways and so on, but our people go inside the home so they can collect cash as well. So those, I think the infrastructure cost, the language or the regional requirements and the technology, all of that gets solved in the process. In fact, in terms of increasing the accessibility, we run patient access programs, which Alam was talking about when we had discussed for the first time, where we are reaching out to about 30 cities in the country, where the drugs are giving at some discounted mechanism or on a which is funded actually by the pharma companies today. So those are the ways we are reaching out to the hinterland.
Thanks. Good to know that. We have about 5-7 minutes for questions and comments and ideas and thoughts from the audience. Please do introduce yourself and ask. We'll keep it short because lunch is waiting.
Hi, I'm Varun from Novartis.
Sorry, can you repeat that?
Hi, I'm Varun from Novartis. So I think a very wonderful session with various sort of experts from various domains of healthcare. So, so we have the drug delivery, we have preventive medicine, and we have the doctor consultation and healthcare at home. So, I mean, there is nothing else that probably comes to my mind. Now, I think I would just like to extend the idea which Vidya had of getting into the aggregator efficiency model. So what happens here is that each one of the panelists are doing great job in their respective domains, but what we probably need as a benefit to the health insurance and insurance industry is a aggregation of the data that is being collected across these verticals, because they are ultimately targeting the same set of customers, the same set of patients. And then that data, once that is aggregated and is interoperable, can then be used by the insurance companies to actually mitigate the risk, both in terms of preventive, consultative, medicine, and inpatient, and then actually come out with a much more data-driven model.
So who should do it?
So I think it's on us, all of us together. We need to form a forum and probably take this forward.
Right, but great idea. Thank you.
Yeah, I'd actually like to respond to that. In fact, the National Health Portal is really
Can you
mandated to
introduce
do
yourself,
that.
please?
I'm Professor Suptan Sarvadikari. I'm leading the National Health Portal of the Ministry of Health, Government of India.
Right.
So the National Health Portal is actually mandated to do that. I mean, to collect such diverse data, be an aggregator, do the analytics. Of course, it's just started, and so probably I think that would be a good way. In fact, some of you are already in our list of useful services. But I think that's the next step, and we should probably work together and see how best it can be done.
Great. Shobha, we already have solutions in the session, so it's great. Anybody else? I saw a few more, couple of more hands.
So my question is to all of you, all the panelists. This sector is very regulated sector, and government is also one of the largest buyer in this sector. So what is your experience in terms of regulation, which results into doing ease of business? Because all of you look for funder, and funder sits on your head for the scalability. So what's your experience on that?
That's a very good point. We didn't really touch upon regulation, but I thought we were still grappling with the insurance companies, so we didn't even get to regulation. Let me collect if there's any more question, otherwise then I'll come to the panel for an answer, and then we have to close right after that. Anybody else from this side?
How will you address the situation of credibility?
Can you introduce yourself, sir? Yeah.
I'm Dr. Sudhir Naik. I'm the Association of Medical Consultants President, Mumbai.
Yeah.
How are you going to address the issue of credibility? I mean, the information which you are providing, how are you going to ensure? I mean, you have, I think Mr. Arora from Librate said, they have a group of 80,000 doctors on their platform. How are you going to I mean, how does the patient choose the particular doctor?
So I think he had partly answered that, but let me now come to the panel and come to, beginning with you, Vivek, address both the thoughts which are raised over here, collecting data, credibility, as well as the regulatory framework, and then we go across.
So in terms of the credibility, I think the way to do it is through technology, as some of us mentioned already. So for example, we capture 300 different parameters on each and every aspect which can be done with the patient. So it's dependent upon the prescription of the doctor, and then we'll capture those results and send it to the doctor. So immediately credibility comes in, and we follow Care Quality Commission UK standards. So you can follow standards like you have NABH or JCIs of the world. You can follow those standards, and technology can do it in a much evolved way than any other way. And I think that's the investment which has gone in from all of us. That's the and other people will definitely add on that. On the regulation side, I think our industry is largely unregulated. Prashant will have his own challenges, but
I can tell you unregulated is a good thing, huh?
no, it's not a good thing actually, because what happens is 95 or 98, 99% of it's completely unorganized market. You don't have any way to differentiate a quality provider from a not quality provider, and hence you have to have some standards which people follow, and we would love to have those standards. Whether it's NABH taking it up or JCI taking it up, we've approached those people, because if you set those standards, at least the consumer would be able to identify, okay, this is a player who's credible. Someone has said that there are some standards which they are following, but the others are not. Otherwise, it's a price game, right? So, yeah.
So on the credibility side, just like any other platform would operate, it's based on user feedback, right? And the way we also operate is, when a user talks to a doctor, based on his or her experience, he's able to say whether it was helpful or whether it was okay experience or it was not helpful. So you aggregate this over, let's say, 1 million times across the network, you get a self-selecting sort of you can see there's a self-selection list that comes up. It says, okay, these are the doctors that are credible because this is what other users have been able to tell. Today, I don't know if a doctor who is sitting in a reputed hospital as well, whether how good or bad things are, because his patient experience is just so diversified that I'm not able to get to all those users, right? But on a platform like a digital platform like Librate, it's actually now possible that users are able to give feedback. And we as a platform aggregate that feedback and show it in some sort of way, which is an easy to understand way for a layman user like myself to be able to say, okay, fine, this means something. I'll be able to, I'll choose him, right? So that's one. On the regulatory side, we are working with one way is to sort of work with others to sort of set those standards, right? So we are working with organizations like Indian Medical Association, which is an apex non-governmental body of doctors, to help define these standards which didn't exist in India, but they have been existing in existence in our Western sort of counterparts. So we are working with the various sort of, you can say organizations to help define those standards. And I'm proud to say that we are sort of one step ahead. Like even today, when there are no standards, we set standards for ourselves, right? So we are HIPAA compliant. We do all kind of security and confidentiality sort of frameworks that we have. But that's on the technology side. But on the caregiver side as well, we are working with reputed organizations to help us define the framework.
Thank you.
I think for us, from a business perspective of effectively what we are trying to do, we don't look at ourselves as a healthcare company. We are a habit formation company, and so for us, we haven't actually run into any regulations or any constraints around that. It's more from a holistic wellness.
But you are focusing on data, right?
Yeah. So wherever compliance comes into picture, for example, we have users in US. Our clients like GE, they have employee base spread in US. So when compliance like HIPAA compliance comes into picture, we make sure that the platform is compliant with that. But there's no regulation that effectively stops us or any constraint around that. To answer the second question on the credibility perspective, it again dives into the first one, because we are not actually suggesting people to to go for a surgery or to do such intensive things. It's more of a behavior change around running, jogging, doing yoga, taking stairs at office, drinking more water, and all those things. So credibility in our case is driven more through users itself. We have machine learning algorithms which predicts as to what you should actually be doing, but we don't get into suggesting people that this is what you should, if you do this, probably your risk of something will come down. So we don't get into that system. We keep it very simple, we keep it fun.
Thank you.
Well, as a sector, we operate in the pharmacy space, so it's heavily regulated, and I think the issue is that with the regulator mindset traditionally has been very much a control kind of a mindset and not an enabler mindset, which is, I think, changing now. So we are engaging very actively with the regulator. I think what we are now seeing is positive movement. They're willing to listen, but innovation by definition is a new way of doing things, a better way of doing things. Now, explaining it to a regulator, whether it fits into their current rule book or they need to look at the rule book to basically accommodate it, is a conversation that we would love to have
I'm sure
faster than
I'm
it
sure
happens.
FICCI can help you on that.
It certainly is helping us a lot in that. So there are a lot of conversations that FICCI has been a very supportive body on that.
And what about the data piece?
I think data privacy and data
And
management.
collection. I think his suggestion was why don't all of you come together and have this data pool which can benefit everybody.
I think pretty much all of us, I think, would welcome that idea. In the US, there are very clear HL7 standards for healthcare data interoperability now. India, it's not up to us to define the standards that we should be operating with. We are more than happy to abide by them. Totally fine if HL7 is what works for India, but that, I think, is a decision beyond my level, at least.
Thank you very much. I have to close the session now. It's a very interesting new set of stakeholders which has entered the healthcare system, which I think is new for them. It's new for almost everybody else. So it's a new member of the family, and this member of the family is young, new, but is going to grow very fast and perhaps change the behavior of the rest of the members of the family as well. So I think it's important that the family sits together across the table and figure out how best to make the most of it. It's a new member, so it is going to make a few mistakes. The older members have to understand how to nurture and grow it in a way that everybody benefits. Thank you very much for joining us for this session.
Thank you, panelists, for a very interesting session.